If your parent is nearing the end of their hospital stay and someone said, "We're sending them to a skilled nursing facility," chances are your first thought was, "Okay, but what does that really mean?" I'm Sandra. I've been a case manager and RN in this world for 21 years, and let me tell you, families are often blindsided by what skilled nursing actually involves. So let's pull back the curtain. Here are 5 things I wish every family knew about SNFs before the first day. Number 1, skilled nursing does not mean long term care. This is the biggest misconception. Skilled nursing is not permanent placement. It's temporary rehab with licensed clinical care, usually for people who still need daily nursing or therapy after a hospital stay. It's a Medicare covered benefit, but it has strict rules. You can't just walk into a SNF and say, "We'll stay a month." It has to be medically necessary. I always explain it this way. When you admit to a SNF, you're admitted with a primary diagnosis. This diagnosis tells us about how long you're expected to stay if there are no complications. It also lays out specific criteria to that diagnosis that must be met in order to qualify for SNF stay and to continue to qualify after you admit. Number 2, Medicare can cut you off faster than you think. A lot of people think they get 100 days automatically, period. That's a nope. You get up to 100 days, but if it's expected that you improve during your SNF stay, your coverage depends on continued progress. If Medicare or your Advantage plan feels you're no longer improving, they can issue a denial in as little as a few days. You need to be ready, and that means having a discharge plan in place that covers the worst and best case scenario. Skilled rehab doesn't mean unlimited therapy and spa treatments. It's short term and insurance driven. Here's a quick tip: you can appeal, it's always your right. Unfortunately, most of the appeals that I see are for 3 reasons. Number 1, the family wasn't properly prepared ahead of time. Number 2, the expectations weren't properly set as to when the patient would be discharged. SNF is not meant to rehab people back to 100%. That's the job of home health after you get home. And number 3, believe it or not, there are actually people out there who just think that they can use the SNF for as long as they want, even if there's no clinical need for it. Please don't be that guy. Those scenarios are collectively one of the reasons that insurances cost so much. Number 3, the care plan is not a secret. You have the right to know your loved one's care plan. Ask, what therapies are they getting? How many times per week? Who's the case manager or the discharge planner? A lot of families don't know that they can and should attend care plan meetings. That's your best chance to ask about discharge plans, goals, and concerns. Don't forget, I made the Caregiver Clarity Kit, which has everything you need for this part of the journey. There's a free printable one, which I always recommend you print out and keep 2 copies. One in a red envelope taped to the refrigerator or to the back of the front door. This is for the EMTs, so they have all the pertinent history that might be needed, and you keep the other one so you can take it with you in case you need to meet your parent at the hospital. Check it out at luminalife50.com to see what I mean. There's also a digital download you can keep on your phone or on your computer and continuously update. I should also mention that I offer one-on-one case reviews. The first 15 minutes are free because we need to get to know each other and get the background details. You can book my time on the website also. Number 4, you can say no to an unsafe discharge. Discharge planning should be collaborative. If you're told your mom's going home on Friday, but she can't safely transfer or toilet without physical help, you do not have to accept that plan blindly. You can ask, how will she manage at home? Who's going to help her bathe? Is home health already arranged? Some of the safe discharge standards are: for mobility, you want your parent to be able to do most things without physical help or weight bearing assistance from another person. For cognition, take into account, first of all, their baseline cognition and where they're at now, and understand that it could automatically be a little less than usual just because of all the hubbub going on around them, like the changes in scenery, all the people coming and going in and out of their rooms at all hours of the day and night to do things like check vitals or check on their roommate, or to give them medication. But also, there's therapy people coming in and out, the social workers coming in and out. There's lots of different rules and times and things to do, and be at dinner at this time and do other things at certain times. So it can be confusing and kind of overwhelming. So even if your parent's cognition is already totally fine, they could be more confused than usual just because of all the stuff going on around them that they're not used to. And make sure that they understand their medications before they discharge as well. That's part of the discharge process. Number 5, dignity still matters. This one kind of gets me emotional because I've watched so many elders become invisible in systems focused only on progress notes and discharge dates. Ask how your parent is toileted. Ask if staff are assisting with eating. Ask what makes them, your parent, feel like themselves, and bring it in: their music, a book, or some photos. Skilled nursing is clinical, but your parent is still a person, and their dignity matters just as much as their progress does. I made this video because too many families are tossed into the system without a roadmap, and that's not okay. If this helped you feel even 1% more prepared, please drop a comment below or whisper "me too" in the comments. And please don't forget, you're not too old, it's not too late, and you are not alone. I'm so lucky to be doing this journey along with you. I'll see you soon.